Okay, well, welcome to the last of the plenary sessions, and this one being on innovative business models. It's billed in the programme as a hot topic, so I hope we'll try and meet those expectations. Certainly, this morning and throughout the rest of this conference, we've had a really interesting, very stimulating debate. The conversation this morning was fascinating, and I think we learned a lot as panel members. And I hope what we can do in this session is share some of those experiences with you and get some feedback from yourselves. In terms of this format, then we'll use the same format as previous plenary sessions. So we'll hear from the panel. We're going to talk about, structure-wise, we're just going to talk about challenges and then opportunities. And what I hope is we might move to some call for action or next steps towards the end of this session. We'll have to see. We'll also try and give some opportunity for audience participation and feedback. So we'll have a couple of sessions where we can try and get your sense of that and ask the panel for probing questions. So first of all, can I ask the panel members to introduce themselves, and I'll start at this end with you, James, if that's okay.
Hi, my name's James Ferguson. I'm an emergency medicine consultant in Aberdeen in Scotland, and I'm also the National Clinical Lead for Telehealth and Telecare in Scotland.
Hello, my name's Stephen Clulow. I work for Nine Sigma, which is an open innovation company. We help companies in all sectors identify partners to develop new products and services. I specialise in the healthcare sector for Nine Sigma.
Hi, my name's Deepak Kalra, and I'm Professor of Health Informatics at UCL and also President of the European Institute for Health Records.
So I'm Lars Sundström, I'm Director of Enterprise for the West of England Academic Health Sciences Network, which is a network funded by NHS England. And what we're trying to do is to create new and innovative models for working with the private sector.
Hello, my name is Adeshino. I'm a founder of a digital health strategy and research company known as Healthronics.
Hi, and my name's Owen Johnson. I'm an academic at the University of Leeds, a computer scientist and co-investigator for the Leeds MRC Bioinformatics Centre. But in my defence, I'm also a managing director of a small e-health software company. So I'm at the forefront of trying to get innovative business models adopted in the NHS, and I'm sure that I think is going to be one of the interesting parts of the themes. Deepak's advice to me at the beginning of this session was the audience will like a heated debate. So I thought what I'd do is I'd sort of polarise the debate. So what I want to do is talk about the challenges first, and we started our panel discussions this morning with what is broken. And that phrase immediately is a terribly emotive phrase. And so we actually had quite a bit interesting debate about whether we should use the word broken at all, and perhaps the glass is half full. Perhaps in the UK we actually do use the money that we spend on health quite wisely and achieve reasonably good health outcomes. So shall we start though? I think let's have a good talk about the broken bit first, because I think that'd be quite interesting, and then I'll try and move on. So I'll ask James to sort of kick off with a description of some of the challenges he's faced.
Yeah, actually just kept in my mind when you said that. You know, it's like, I've got an iPhone 3 in my pocket, which is a bit embarrassing. But the point is, if it broke, would I fix it, or would I go and get a new one? And I think that's, there is nothing wrong with my iPhone 3. It functions well, and it functioned well when I got it in 2010. But is it appropriate for me to just fix that, or do I move to something else? And I think that's the sort of analogy for the problem we've got in healthcare at the moment. The system, and two speakers yesterday spoke about how we are still using 19th century organisation in the 21st century. And the challenge I find as a clinician is that our system is very good. We had a very good system when it was set up in 1948 in the UK and around the world, which was designed for a population that they were dealing with at that time. The problem is that we've not really moved forward with it, and in fact we're almost held back by trying to use existing methods of delivering care, but just fix them to work a bit better. And I think we were talking about Africa this morning, and I've been involved in a couple of projects, and some of the other guys have been as well. And the interesting thing is that in these countries that had no infrastructure, no pre-existing healthcare mechanism, they've gone straight to mobile. They've just adopted mobile straight from the word go. Yet, in the Western world, we have all these existing systems that we keep trying to milk and just work that bit better and not really applying digital health well enough. And some of you were in my talk yesterday. The problem, we talk about the elderly population being the big problem. We're seeing that problem now. In the UK, A&E departments are overflowing. And that is partly a result of the fact that we have an elderly population. But the other thing is, it's actually more down to the fact that the system we have for dealing with these patients is not appropriate for the population we're dealing with at the moment, to the point that mortality rates are increasing. So this isn't just an organisational thing, it's a quality thing. We are killing patients by sticking to our current mechanisms without actually embracing digital health to transform how we deliver care and actually create a new mechanism for delivering care rather than clinging to the old one. So it's not good for us, it's not good for the organisation, it's not good for patients. So we're killing patients at the moment if we don't do something different.
So thank you, James. That's the sort of emotive start that I wanted. So we're killing patients by not embracing digital health. Can I ask the other panel members to chip in? Stephen, would you like to?
Sure. To perhaps build on what you were saying, I think one of the challenges that we spoke about this morning was short-termism. So one of the challenges that all healthcare systems face is that people are living longer. There are people with long-term conditions and multiple conditions, complex conditions, and that requires much longer-term management. Whereas in all the systems we have at the moment, we're locked into annual budget cycles. And it's very difficult to get long-term investment, long-term reimbursement for any sort of intervention, be that a digital intervention or a non-digital intervention, that's going to deliver a benefit in 5 or 10 years' time. And that part of the system really does need to be changed, because we need to be helping people today to affect positive outcomes in their long-term conditions in 10 or 15 years' time. And that's a really difficult thing to do at the moment. So I think that's one aspect of the system that we spoke about. The other aspect of the system that we spoke about that is a challenge is a huge amount of innovation is going on in small companies. Yet it's incredibly difficult for those companies to establish the relationships with the NHS, to get through all the purchasing procedures and successfully sell their products so that the small company can grow and make a business, but also so that the NHS and the patients receive the benefits. So two, perhaps, challenges there.
Okay. So Deepak, would you like to talk about the challenges that you see?
Yes, I'd perhaps like to begin by saying we need to be very careful if we talk about things being broken. Not really, because we must remember that the National Health Services, and we have a few of them in the UK, are staffed by many, many thousands of people who are largely doing their best to deliver a service that still has a lot of public respect, still does a lot of good. And although we are change agents here in this panel and in this room, we must be careful not to undermine the mood and the dedication and vocational spirit of all those people working today. So let's be careful with the word broken. However, our paradigm, our conceptual model of a health service is out of date for 2015. And I absolutely agree with both previous panel speakers about that. We are still operating a paternalist model of healthcare delivery, and we are centralizing the delivery of services into institutional entities such as GP practices and hospitals and care centres, as opposed to operating a distributed, empowered model in which a lot more of what patients and their friends and families can do is part of that co-production. So the conceptual model needs to be changed, but let's please be kindly and sympathetic and actually recognise the worth of our wonderful staff in the NHSs.
Thank you. So Lars.
Yeah, I'd like to pick up on a sort of a middle ground from some of the points that you made, and that's one of the things that we discussed is where does innovation actually happen and where do people take the risk to do innovation, because you're in a system that's under continuous pressure to deliver more with fewer costs. It's difficult, and it's difficult to take the risk on SMEs, for example, to bring them in. And I'd like to stick up for my procurement colleagues that I've actually found them very interesting to work with and very, very well educated on the problem. The problem they see it, as they say to me, it's not my job to try these things out. It's my job to procure things that actually work. So the question really is, where do we do this innovation? Where does it happen? And I think we need to create some intermediary structures where it can happen.
Well, can I challenge you? Just because you want some controversy?
Exactly, thank you. Yeah.
Just a quick question
Yeah.
back to you. If procurements can't be exploratory, then actually are we not risking continuing to procure, if you like, old-fashioned solutions, creating no market opening?
Yeah.
Surely procurers have to be a bit brave at times and be pioneers too.
I completely agree. Actually, I totally agree with that point as well.
Okay.
So I think what we need to do...
Sorry, I failed, Owen, to stir up blood.
We sadly,
Yes.
we spent far too much time agreeing with each other that it was complicated. But so Lars, go on.
I was just going to add that I think the procurement people are part of the answer rather than the problem. So essentially they're open to these new ways of working, but currently that's not the brief that we've given them to work on. We've given them the brief of buying stuff cheaper and making it work faster.
Then I'm sorry, we agree completely. That's not good for the audience.
Not
sorry.
great, sorry.
Yes, I would like to start by saying that medicine is not risk averse when it comes to innovation. Okay, we know about so many drugs, as in so many lives have been saved today because of the drugs they are using. Some of them were developed by doctors in collaboration with scientists. So many diagnostic devices that we're using today were either invented by doctors or developed together with doctors, ophthalmoscope, stethoscope, MRI, CT scan. So it's not that healthcare or medicine is not innovative. The problem I think is that because it's digital is a different type of technology that the healthcare is not used to, because the other technologies that I've listed actually originated within the healthcare system or within the medical system. Digital, although in its earlier origin, because in America, it actually computerization co-evolved with biomedical sciences, but since then, it left the medical arena and went to the mainstream. So it's like you are introducing a technology that developed outside the mainstream healthcare system to the health system, and that's where we get in the adverse reaction from doctors because it's not really something that inherently originates from within the health system. So coming to the question whether the health system is broken or whether it's broken or not, I don't think it's broken. I think it's getting its orientation very wrong. Instead of focusing on acute care, I think we should focus more on prevention, because for digital to work, we need to keep more patients or citizens away from hospital. And the way to do that is to promote to reorientate our healthcare system to promote well-being, wellness, and prevention, and preventing people from falling in and coming to the hospital.
That's right, thank you. So one of the challenges that we talked about was whether it's possible to do incremental change, or whether actually radical change is needed, and whether the only radical change is whole systems change, and if whole system change is needed, how do you go about that? And Chris Folks was in on the debate, and we talked about the platform, the network effects, and maybe one solution is to start building new models of healthcare completely independent and away from our current models of healthcare, and let them evolve and let them sort of establish themselves as a rival, and then gradually fold in to a new model of care. So that's quite an interesting and challenging concept. So I think
I have a problem. It's not. I agree with him that we need a parallel system of healthcare, but if we don't change the underlying financial incentive, I don't think it's going to gain traction. The reason in America there's probably 3 parallel health systems. You have the private, the public, and the community health system. The private is 55%, and then the public sector is 45%, and which by virtue of that supplies the community center. The reason why the digital health economy in the US is more vibrant than we have anywhere in the world is because that 55% that is private is always open to innovation, always ready to drive efficiency, always ready to satisfy their patient's need. In the UK, it's 90% public and 10% private. Even the 10% private are actually contractors to NHS, so they are not independent. So because they are not independent, they cannot drive innovation on their own. So if you want to have a parallel system, if the financial incentive is still 90-10, it's going to be difficult because it all starts with the money. And I think that's why I have a problem with the platform model. If you don't change the underlying financial incentive, the platform model or a parallel health system will not work.
Okay, so
Can I be controversial and disagree with my colleague here? In the sense that I would not favor moving to the US model at all.
No, I'm not saying we should move to US model. I'm looking at the principle of how the system is working.
Well,
Okay,
we're talking
not
about,
going to the model.
Talking about what's broken. One thing that's not broken in the UK is the US spends 20% of its GDP on health, and we spend 9%. And we have
No, it's
better
not
outcomes.
20% and it's 16%.
Okay.
And
So
it's
I
17,
think
and
I'm gonna.
it's the biggest chunk of US economy, so it contributes to the economy. That's where the biggest medical device companies, the biggest pharma companies, the biggest digital companies, they are all in America, and UK taxpayer money has been used to buy drugs and software from them. It's because of the money they spent on the healthcare. The healthcare is a demand matching.
Time for the audience to have a say, I think. Before they start falling off chairs and hitting each other, then can you help here? We've got some microphones. So, any comments from the audience? Can you take this one? Thank you. Can you just say who you are?
I'm Matthew Thomas, Public Health Wales. So my question is about public health and private companies. How could we conceive of private companies actually doing what we're saying, which is to keep patients from entering the health service by keeping them well, etc., or delivering the service in their home, etc. How can we envisage that health promotion and health intelligence function coming from commerce?
Yeah, Lars, do you want to come in on that? Because
I didn't hear the question properly.
Okay, so if I'm right, how can we allow innovation coming from commerce into a largely state-dominated sector? Is that sort of reasonably accurate?
Yeah. I think it's a difficult one, isn't it? Because essentially what you have is a centrally procured, centrally delivered system. In fact, it's quite. I hate to use the word communist or socialist in its underpinnings, but it is. So trying to bring in private enterprise into that is always going to be difficult. But I don't think it's impossible. I mean, there are other sectors that do it quite well, defense, for example. So I think what we need to do is to move to a system where what we're doing is procuring innovation, in quotes. In other words, we can start with a problem, opening it up to as much innovation as possible. I think those are the kind of models we need to work on, rather than having, as you said, suppliers have been supplying the same stuff forever and trying to get it cheaper.
Okay.
I mean, we buy drugs, we buy beds, we buy catheters, we buy light bulbs. So it's not as if commerce doesn't have a purchase into the health system. We buy things. The main problem is creativity doesn't have a look in. And I think what we need in that health promotion space that you referred to is market creation. At the moment, there is not a financial model that underpins wellness in the way that we have a financial model, whether we like it or not or think it's old. We have a financial model that underpins fixing people when they're ill. We don't have a financial model for looking after people and keeping them away from getting ill. And until we have that financial model, which is the bit of the health service that does need to be somewhat reinvented, we don't have enough breathing space for creativity. And I think you're absolutely right that when a financial incentive environment exists, innovation does come in. Yeah. And I do believe that healthcare is innovation positive. It does welcome innovation, but there's no breathing room at the moment. There's no financial breathing room.
So can I ask, there's a lot of small business people, industry members here. How do you feel about innovation? I mean, obviously, I think the sources of innovation quite often come from small businesses, we think. Yeah. And I just wonder if there's people here that would like to reflect on that. So.
Michael Sears, yeah.
Hi.
You might want to.
My name is Michael Sears. I'm a patient, and also a small business owner that's developed technology for bowel patients. And it was developed on the ward in hospital in the UK. It went through CE marking and MRHA approval, and at the same time full FDA approval in the US. I come out of full FDA approval in the US, and hospitals engage instantly with a commercial discussion. I come out of regulatory approval in the UK, there is absolutely no pathway for engaging or adopting that innovation. So a device that's developed on the ward in a hospital here is now being embraced in America in over 40 institutions, but I can't get NHS Business Services to adopt it because they have no model for adopting innovation.
Okay, Ed,
So I'll be proving right,
do you
right?
want to so, well, should we just check? Are other people in the audience that are from the world of business, are you having the same challenges? And are they different in the UK to other countries? Or do you want to speak from your experience?
Just one suggestion I have for commercial business try to push digital product in the NHS is that you need to demonstrate immediate value. Because if you're looking into history, the technologies that have been successful in medicine or in healthcare system, they demonstrate immediate values. Like most diagnostic technologies demonstrate immediate value. If you have a patient in front of you, the only thing you have is to palpate. And if you're very good with listening with your ear, to put your ear to the patient's chest. But we inverted stethoscope to be able to listen to the chest. And also, if listening is not enough, if sound is not enough, you want to see what is inside, then we inverted X-ray. So it demonstrated immediate value to the doctor for treating the patient. The problem with most digital products is that they are not demonstrating immediate value. And how do we do that? And I think it's a key issue that needs to be addressed by people coming from the commercial sector.
Mm. So anybody from the commercial sector like to join in at this point? But can I just speak from my own experience instead of... so I've run a small business for about 8 years. We have a very simple software as a service model to remove paper-based processes from laboratories. It's taken the best part of 8 years to get up to 40% penetration in the UK NHS. Every single procurement that we go through, and this is a £8,000 a year licence fee, it's hardly anything. It saves £30,000 just on paper. Over and over again, the barrier is NHS procurement processes. Over and over again, it's the amount of time and effort that as a small business you have to go through to try and persuade every single NHS organisation separately. And so I don't know if those of you that are in NHS organisations, can you make it easier on behalf of small businesses to innovate?
I think you can, and I agree with that point, that is the big barrier for SMEs in particular, that they find it almost impossible. And it is a very sad maxim that when you advise companies to develop something, you say don't start in the NHS, go and do it elsewhere and come back once you've developed it. That is what needs to change. What I'm arguing is that procurement on its own can't do it. You need the space where that innovation can happen. You need somewhere where it's safe to take risks and things, and it's safe to fail. And currently there isn't any space either financially, as you're arguing, or in terms of actually trying out multiple solutions to figure out what's there. So we need a completely different model where it is okay to try those things, and also a model for spread, that once those things actually work in one place, why would you have to go through the same thing again? And then we have 360 CCGs. You sell it to one, you have to go and knock on all those doors and go through the whole thing again. And that's completely wrong. That's what needs to change.
So Stephen, do you want to?
And I think that a point about adoption is absolutely critical. If you think about the adoption curve for innovations, you need early adopters to drive that adoption curve forward, and then the mass of people follow. But in the medical sphere, people are naturally quite conservative, because there's a risk to the patient at the end of it, and I quite understand that. I think one of the really powerful things that the NHS could do would be to set up a system whereby once something has successfully proven itself, in pilots and got certification, that is announced and broadcasted across the NHS so that people who could use it can see it and they can start to influence the purchasing process around that. I think there's not enough visibility of potential innovations and the data that proves they are safe, efficient and deliver benefits in the NHS at the moment. And that dispersion and adoption part is needs really working on.
So, James, I think it was either you or George Crooks that described the Scottish health system as Stalinist.
Yeah.
But yet still able to innovate. And what's the secret?
Well, yeah, we're able to innovate, but we can't disseminate. I mean, and that's the real nub here, is that, for us supposedly being innovative, we've come up with lots of ideas. And I think the key thing to this is that the emphasis, particularly in the NHS, is for us to prove to the NHS that what we've got is better and safe than what's happening at the moment. Very seldom when I get challenged on this, when I turn around and say, can you show me the data on the clinical effectiveness of the existing, system you're using? So, does every patient that comes to your clinic need to be seen in the clinic? Could they be seen by video conferencing? Could they be dealt with by email? That, and you go, where's your data for why bringing somebody into hospital there? And not one of them. They just look at you and go, but that's what we always do.
Exactly.
And it's up to you to prove it. And the thing is, well, I am now proving it to you repeatedly that there's benefit. Now it's up to you to grab it. And we're great on evidence-based medicine, which I call, EBM is effective barrier to modernisation as far as I'm concerned. We're always trying to decide, who pees furthest up the wall. It's like, this drug's better than this drug, right? And then when we do that, we start, usually use it in a hospital, and we use this expensive new drug, and then we apply it to a population in whom, in the controlled trial, they were all excluded. So we actually have a system that takes some drugs that were tested in people 60, 80, apply them to 80, 90-year-olds, and kill them. Because we haven't done the study which says, right, you've got this new drug, what is the best way to deliver that innovation in your healthcare system? We always go back to our traditional hospital, GP, prescribing, and whether it's appropriate for you or not, you're getting it.
So there is one of the challenges of innovation,
I
which
think this
there's a
is
limited
where
evidence
we
base.
should now be looking to support the EMA with its adaptive licensing strategy, which is trying to address that problem.
Okay,
but it's a very real problem.
Can we just take audience feedback?
Can I just lead on from that? I hope this isn't a heretical view, but it may be. I think the point that we're missing here is I think we need to change the paradigm in terms of supplier and customer here, because from an NHS informatics perspective, we come to conferences like this. We've just been blown away by a presentation from another country this morning. All of that stuff is there. And as you've just said, there's no shortage of good ideas. I think part of the issue is where do those good ideas fit into some kind of a priority? And the key piece for me is we're asking the guys that are doing their best to keep the lights on to engage on the next big idea. And the real issue here is capacity. And it seems to me that the answer to that particular problem is not customer-supplier, it's partnership.
Mm-hmm. Absolutely, thank you. Yeah. So one more.
Dr. Amir Hanan, GP over in Manchester. Patients, carers and information are the most underutilised resources that the NHS has, and in fact healthcare right across the world. 33% of my patients have access to their GP record, and they can share their information with whom they like, whenever they like. All of us are wanting to do the best for us. We want to prevent heart disease, diabetes, obesity, depression and all those sorts of things. People are coming to see me, expecting me as a GP to be able to fix them. And as we know, they're getting worried, they can't get into their GP, so they're ringing the out of hours, they're ringing 111, they're going to the A&E departments. Everyone is struggling. Let me tell you, the next blockbuster drug that's out there is not going to be a pill, it's not going to be a tablet, it's not necessarily going to be e-health, but it is going to be this empowered patient. And the more we start to think about building partnerships in the way that this gentleman's asking about, the more we start thinking about the ICD-11 that Ustan described just now, the more we start thinking about how we can work together to support and empower patients. Because as a GP, believe you me, when 50% of my patients that I'm seeing in a normal surgery have got access to their records and they can go home and they can read what they've written, they're not ringing up the surgery, they're having blood tests and then going online and looking at their test results. They're going home and they're telling their spouses, their children, who might be on the other side of the planet, to keep an eye on what's going on and making decisions and things. And then start thinking about these people who are empowered, who've got their, not just their data, but their knowledge. That's the key, it's sharing that knowledge. And then you start thinking about the wonderful apps and things that you could do to support those people. That's an incredibly exciting place. I've put a tweet out to talk about this empowered, this blockbuster drug, because that blockbuster drug is now here, it's available, it's slowly growing, but I'm not sure we're fully recognizing them. How many people here have got access to their records? Yeah, we've got one person here, and we're talking about e-health, and we're thinking about how to sort it out. How can we change that?
Okay, panel, would you like to respond? Deepak, I think, do you want to?
Okay, well, I mean, I love everything you've said, Amir, and I really support that vision of the partnership model as opposed to the paternalist model of healthcare. But our topic is innovative business models. And what concerns me a little bit is that when we have patients with long-term illnesses who are able to do more for themselves, probably manage themselves better than in the paternalist model, they will have fewer GP consultations, hopefully. They will have fewer bed days, hopefully. But the savings that occur to the health system are not able to be ploughed back to support that patient. So the cost for the patient and the cost of any adaptation to the services to support the self-caring patient are unfunded, and the savings are just clawed back elsewhere in the system. So what concerns me is how do we create the business model to scale up that vision you've just beautifully described?
Okay, so that's quite interesting. Did you want to?
I don't know where the problem lies, whether it's with the patient or with the system. If you remember, under the National Program for Health IT, there was a PHR platform, the health space. It closed down. The uptake was less than 0.5%. It was an absolute failure. And yeah, you could argue that the interface was clunky, it was not mobile, it was only web-based on the internet. But that's kind of pointing to us that I think in the UK, patients or citizens are not really consumers when it comes to healthcare. And I don't know whether the problem is with the patients themselves or the citizens themselves or the problem with the health system giving patients and citizens incentives to be responsible for their healthcare to the extent that they be willing to go online and audit or curate their health record. There's a data that is being banding around that about 30% of people in the UK actually go online to audit their bank accounts or to look at their bank accounts at least once in a month. If only 30% of people are doing that, and money is more important to most people, if you ask them, people will take money before their health care. So that means that the uptake is actually very low. So where do we change from? Is it the health system or the patient?
Okay, so you've got a response to that?
It's really interesting. We've been enabling patients to access their records for 10 years, and the culture is changing. So those patients who first started looking at their records, they're now starting to develop their own ideas. And I'll just give you one very simple example, and one that we could all take away. Many of you will have heard us in the UK that we had NHS Change Day last year, and over 1 million pledges were made by members of staff looking at things that they could pledge that could make a difference for their health. Well, one of my patients, Ingrid Brindle, is the chair of our patient participation group. She heard about this, went away and thought, there's a trick here that we're missing. What if each of us, every single person in this room, pledges to do something for their own health? Something very simple, like drinking a glass of water. maybe walking 5 steps. For me, it was stopping eating crisps or going on a treadmill 3 times a week. On the first one, I managed it. On the second one, I've done it about 80% of the time. I need to look at my data. But the point I'm making is actually, in order for us to move to the next level, we've all got to have a sense of ownership. And what I'm seeing, and what they did is they set up a website, healthpledge.co.uk. Again, I'll tweet it out, but please, every single one of you, pledge something that you can do today for your own health. Go back to your family, invite them to do a similar thing. Wherever you are, you could be in Turkey, you could be anywhere in the world. And if we all start doing that, just imagine the impact that could have on communities and systems. But the wider one, the one that you've asked, I was on the Health Space Reference Panel, so I used to go down to London, I used to hear their figures, I know exactly how many people were using it. And I've also got a good understanding of what happened with Health Space and what's been happening in my practice, where a third of my patients are accessing their records. And Dr. Caldera pointed out very clearly this issue about partnership working. When did anyone ask any of us to go on to Health Space and use that? We simply didn't. We continue to say the NHS is going to be there for you. My patients don't come into me and suddenly say, I want access to my records. We have to have a conversation. We have to create an interest. We have to engage with patients. We have to start thinking about not the fact that they're in front of me, but what happens when they fall ill on a Saturday and they turn up at the out-of-hours service or whatever it is and they don't know anything about it. We have to inform them. The number of people today where I've shown them people apps about what they can do and they go, I've never seen this before, no one's ever seen it. I'll tweet out the test patient record. You can download the app on your iPhone or your Android. You can use a test patient and try it out from anywhere in the world. When people see the art of what's possible, but what I want us to do is not just think about patients accessing their records, but think, what can you do in your own individual role, whether you're a clinician, manager, developer, to start to support a patient who can access that data and help them to get a better understanding. I talk about records access and understanding, because actually it's the understanding that's key. It's not just accessing your data. And if we all start doing that, and that's where, if you listen to Michael, I don't know, Michael, if you want to add some more comments, but if we all start to support patients, we'll empower patients, we'll empower ourselves, we'll empower our staff, we'll get to the next level of healthcare. I don't know if, Michael, you want to say something about that?
So I think the interesting challenge here is patient empowerment is an unstoppable force. It's going to bang into the big mountain of our healthcare providing system. And so the interesting question is, how does that collision take place? Does that collision take place in a managed way? Or is there a lot of blood on the carpet? And how does that play out? So Michael, did you want to add on to that?
I mean, look, the facts are at the moment the patient movement that Amir refers to is light years ahead of the healthcare system.
Yeah.
And actually what we rely on right now are incredibly brave clinicians like Amir, who will engage with us in the way that we want to engage. And unless that culture change happens, unless that fear factor goes from no we can't to yes we can effectively, I think patients will develop more and more things to look after their own conditions that will be light years ahead of the system and innovate. There are so many patients out there innovating every single day to manage their conditions that doesn't ever scale up.
Okay, panel, do you want to respond and then we'll take another
I just want to pick up on that point. I think the whole idea of partnership is absolutely correct, and that you need to move to that co-creation and co-design kind of thing. And there's some good pilots that are actually running, some good ones here in Wales. For example, the South East Wales Academic Health Science Partnership and their Health Tech Challenge, where effectively these are unmet needs that the patients have actually put forward and transferred directly out to SMEs to develop them. You don't even have to use the healthcare system to do that. So I think that's the kind of ecosystem that one needs to kind of build. It's that network effect. The more you do it, the more, and you're quite right, the more people realize it's there, the more it's going to happen.
Okay, just one more comment from here.
I'm Sarah Hayes. I'm Director of Public Health for the neighbouring health board. It covers Swansea. I've got a question. The Welsh Government, for the first time, has allowed the health boards to develop 3-year plans, so we're not tied to the 1-year schedule anymore. We're looking at 3 years. We're into the 2nd year now. Do you think that will help us take on commitments from small businesses? Do you think that will sort of open up the planning arena and look at the 3-year timescale?
Yeah, it will really be helpful. I speak with a lot of startups and small businesses. Of course, their greatest challenge is getting to the NHS. Of course, that is very essential. If the NHS control 90% of the budget of the money, you need to get to the NHS to scale up. So I think is an important step forward, but you need to be very proactive in making it to work. The problem is not about strategy or policy. It's about getting it to work. And it's about the NHS understanding the nature of digital health. Digital health is not going to work with the existing business model. You need to go out there, you need to explore, you need to experiment to know what is going to work. At the moment, we don't know what is going to work.
So is the question for the panel then, is it that we need strategies which allow us to procure innovation? And is it, are we locked and stopped because we can't procure?
Well, I think we need more than the things we've described. So I think a 3-year planning and financial return cycle is critical. A year is just a waste of time for being creative. We know that. I'm actually not sure if 3 is enough. I think you need almost the ability to have 3 to 5 based on the business case of the intervention you want to introduce. But it's not enough, because if we have hard-worked, struggling to cope staff, then actually there's no capacity to innovate and change at the grassroots level. So we don't just need the time slack that you describe, we need some funding slack, some ways of introducing a bit of capacity uplift into subsectors that are about to experience a change to help them make that change. But actually, even more important, you asked about whether the patient empowerment process will be a collision or managed. What I feel we are lacking is a patient empowerment strategy that looks at how are we going to benefit from, harness and focus the momentum that Amir described. My concern is that the patient's energies for taking control will be diffuse. And if they're diffuse, we won't have a chance to leverage their potential to the best.
Okay. Thank you, Deepak. Can I ask other members of the panel just to summarise? Have we got a nice positive ending for the conference? What's the future here? Should the next one be called Open Adoption International Conference rather than Open Innovation? Is that the challenge? But just some concluding remarks.
So I think for me, I absolutely take the point that what I'm going to call the consumer-led market, the patient-led market, is going to be one of the big drivers of change. I think the important thing that the healthcare system in the UK needs to think about is to have the flexibility and adaptability to respond to that. And building in that flexibility and that adaptability is really important. I think having longer term horizons is absolutely key as well. And what I would say there is that gives you the opportunity to experiment and try things. I'm not sure we're ready for failures. And part of innovating is failing. If I was working with the health board to look at the 3-year strategy, I would say invest in innovation. Don't invest in just one project. Invest in a portfolio of things that you hope are going to make a difference. Don't expect everything to succeed, but when something does, really drive that through and make sure that it gets adopted and used as widely as possible. And don't let your colleagues beat you up for the 8 out of 10 things that didn't work, because those 2 successes are going to more than pay for everything else.
Okay, thanks, panel. That's absolutely great. This is all we've got time for in this discussion, but it will continue in the session after this. So if you'd like to join us and continue that discussion, please do so. I hope it will be a discussion that we'll be having back home in our working lives. This is the hardest bit to do. The challenges are not easy, but they must somehow get done. I think the imperative is there anyway. So can I just thank my panel members for a hot and lively debate. I hope that was as hot and lively as you were hoping. So thank you very much, everyone.
Thank you. Thank you.